I would next like to invite Dr. Sivani, who will be speaking on ocular surface disease and glaucoma medications.
Good afternoon, everyone. I am Dr. Sivani. So, I will be presenting on ocular surface disease and glaucoma medications. So, the objectives of my presentation are to discuss the clinical features of drug-induced pseudopemphigoid and discuss the management of glaucoma in this case. So, usually, such patients usually come to our OPD with chief complaints of redness, watering, and photophobia. Even in few cases there could be like itching, pain, blurring of vision and foreign body sensations, but it is usually localized to the eye in which the patient is using medications. So coming to the history, generally these patients will be treated elsewhere as chronic follicular conjunctivitis with no relief of symptoms. In this also we can see only in the particular eye in which the AGMs were taken. So in the history we need to go back and ask the patients whether the patient is using on any anti-glaucoma medications or not. So now I want to discuss like how these anti-glaucoma medications act on the conjunctiva. So the mechanism by which this conjunctiva can react to these medications are like it can form cicatricial conjunctivitis or any anaphylactic reaction, which is type 1 hypersensitivity reactions, or any allergic contact dermatoconjunctivitis, which is type 4 hypersensitivity reactions, or it can form any non-specific irritative or toxic conjunctivitis. So the potential factors for these adverse effects on the conjunctiva are due to the type of medications what the patient is using, or due to the preservatives or number of medications and duration of the therapy and frequency of these medications or physiological properties of these drugs. The spectrum of this conjunctival reaction can vary from total tolerance to severe clinical disease. So various clinical presentations include like in the skin it could be like skin excoriation, lichenification. In the lids it can present as entropy and punctal stenosis or keratinization. In the conjunctiva there could be follicular reaction, fibrosis, phoneal shortening and symblepharon. In the cornea there could be superficial punctate keratitis, ulcers or opacification with vascularization, and in the lens it could form cataracts, and in the retina it can even cause cyst or macular edema. So there are a few photographs of these presentations. Like in the skin, whenever these AGMs come in contact with our skin directly, it can form skin excoriation, and it thickens to form this lichenifications. And in the lids, it can form lid thickening, entropions due to this fibrosis, and punctal stenosis, keratinization of the lid margins, hyperemia of the conjunctiva, follicular reactions. Here the follicular reaction is usually seen in the lower tarsal conjunctiva than in the upper. And this subconjunctival fibrosis, phoneal shortenings, symblepharon formations, medial canthal keratinizations along with ankyloblepharons, superficial punctate keratitis, pannus formation, and at the last sterile corneal melt, and even sometimes it can form into opacification with vascularizations. So all these come under the category of drug-induced pseudopemphigoid. So what is drug-induced pseudopemphigoid? So it is a clinical findings which is identical to mucous membrane pemphigoid, which occurs usually in response to varying offending topical and systemic drugs. But in drug-induced pseudopemphigoid, there will be absence of any systemic features which are present in MMP, and it differs from MMP like it is usually unilateral, and the symptoms are localized to the eyes in which the patient is using AGMs, and it is non-progressive in nature, whereas MMP it is progressive in nature in spite of cessation of the drugs. So the criteria for pseudopemphigoid is it is a chronic cicatricial conjunctivitis along with the history of absence of alternate cause of cicatrization, and biopsy we need to rule out MMP. So what could be the differential diagnosis for this? It is pseudomembranous conjunctivitis. As I already told, these patients will be treated elsewhere as conjunctivitis for longer period of time. And in the main differentiating feature is in this conjunctivitis, both upper and lower tarsal conjunctiva will be more or less equally affected, but whereas this here more often lower tarsal conjunctiva will be affected. And it can also present, one of the differential is trachoma sequelae, where upper tarsal conjunctiva will be affected with pannus formation and lid anomalies. And the other one is ocular cicatricial pemphigoid, where it is progressive and systemic involvement can be there. Coming to the management, the aim of treatment is not only to treat ocular surface management, but also to control intraocular pressure. So to control intraocular pressure when in the state of cicatrization, when it is early, We can either do trabeculectomy or implant when the conjunctiva is healthy, but when it is in advanced cases, we need to switch to preservative-free alternative drugs and reassess intraocular pressures. If the intraocular pressures is well controlled, we can continue anti-glaucoma medications, but if the pressures are not under control, even with preservative-free medications, we need to go for conjunctival sparing surgeries like cytophotocoagulations or laser trabeculoplasties or MIGs. So coming to the surface management algorithm, we need to control the surface inflammation by giving topical steroids or immunosuppressants, and to improve vision, we need to give intense lubricants, glasses or scleral contact lens, and we can even go head-fed with the keratoprosthesis. To arrest the progression, either we need to withdraw or replace the medications which the patient is on. Coming to the prognosis, persistence of ocular lesions without progression is seen in 43% of the cases, and the recurrence is seen in 8% of the people. So my take-home message is underdiagnosed in its early stages due to failure of recognition. So high index of suspicion and a greater awareness of this condition is essential to identify the predisposed individuals early in the disease process and treat appropriately. Suspect AGM toxicity in case of non-resolving chronic follicular conjunctivitis, and drug history and careful clinical evaluation helps in diagnosis. Stop the offending drug is mandatory, and appreciating cicatricial changes as a complication of glaucoma therapy and actively looking for it in each glaucoma patient at every clinical visit will be simple, rapid screening measure.